So we have many issues, but I don't think our system is falling apart. Um, it's just a perfect punching bag for critique, for criticism, because it deserves it, right? Is it Canada? Is it France? Are there other examples that you look at?
Ironically enough, I don't think Canada's is that great.
Right.
And they don't have as much of a private outlet. They really force people to stay in the public system. Therefore, they have significant wait times that people complain about with no way of getting out of it. It's ironic to me that that's the system that we always point to in America is like, that's a great option. It's like, that's the one I wouldn't pick.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoy today's discussion, please take a moment to sign up for your preferred membership level.
Hello and welcome to the latest edition of Scale Community's Analyzing Healthcare. I'm joined this morning, still morning, with Aaron Carroll, who's the president and CEO of AcademyHealth. Welcome, Aaron.
Thanks for having me.
My absolute pleasure. So for those who don't know the history of AcademyHealth, and I think it goes back many decades. I think there was originally Alpha Center and the Association for Health Services. So this form of US focus, advocacy, and research, understanding our marketplace and communicating that back to our regulators, that has been going on for a long time. Do you want to give us a little bit of background on AcademyHealth? Sure.
Sure. So, Academy Health, and I think it's interesting you bring it up. It resulted from the merger of two different other organizations, one of which was a strictly membership organization. It was the professional home for health services and health policy researchers in the United States. And the other organization was more of a think tank, research-oriented shop that did work on sort of what we would consider health services or health policy research, looking at the access, quality, and cost of the U.S. healthcare system. When they merged into one group in Academy Health, that's how it came to be. And so our mission is to promote and encourage the use of data and evidence to improve health and healthcare for all. But we are also the membership organization for those that do that kind of work. And so we have an advocacy role, we have a communications role, we have a membership support role, and we help again, to facilitate the production and use of data and evidence. So we are just really invested in how we can help others to both create the evidence base that we need to improve the healthcare system and also to make sure that policymakers use that data and evidence to improve everyone's health.
It's a wonderful time to be speaking to you because, as always, healthcare is going through a lot of change and a lot of vitriol and bipolar views on which direction. And while that's happening, a lot of noise, but some substance too. We're seeing premiums increase this year across the board by 10, 20, 30, 40%. And we're seeing expectations of coverage drop off measured in maybe millions, if not tens of millions of US citizens. So a lot of volatility in the space today. And so a wonderful person to speak to about these changes.
Well,
What are
appreciate
your
it.
thoughts on the state of the industry right now, given the drop off in funding and subsidies for ACA, given the sudden, almost immediate implications for premium increases, cost of healthcare increases, and loss in coverage?
You're right. It's an interesting and somewhat fraught time, especially in America. You can talk to 10 people and get 11 different opinions as to why that is and how we should fix it. But the truth of the matter, it just comes down to the fact that healthcare in America is incredibly expensive. It's the prices, as many, many, many studies have shown. Everything in the United States is just so expensive. And many of the problems that we see that you just described are really due to, I think, to the fact that politicians and policymakers in general really don't want to confront that hard truth. There are no answers to the high prices of healthcare in the United States that require no trade-offs. If there was an easy solution by which we could reduce healthcare spending and yet improve access and quality at the same time, we would all do it. There just isn't, even though everyone keeps promising that. And so any decision that we make requires significant trade-offs that no one wants to address. And so what we're seeing right now is the fact that it is incredibly expensive, and making it not terribly expensive for everyday Americans requires significant investment of tax dollars. There's just no way around that in terms of subsidies. Those are very expensive. And that's money that we can't spend on other things. And as the current administration wants to spend money on other things, they have to find it somewhere. And so they're finding it by reducing Medicaid spending and by reducing subsidies in the Affordable Care Act, or letting some of the, increased subsidies expire. That means that healthcare insurance becomes incredibly expensive for many Americans in the exchanges because those subsidies are ending and prices are not going down. And likely the outcome of that will be that many people will not be able to afford insurance and therefore will go uninsured. I think what we're seeing around the rest of the country, with people seeing their premiums even in employed situations go up 10, 20, 30%, it's the same reason. Healthcare is very expensive, and we keep trying to find ways to shield people from that, but there isn't. It's just math at the end of the day, and someone has to pay the bill. And in this case, it's going to be employees. It's going to be people on the exchanges. It's going to be everyday Americans who are going to suddenly be exposed to the fact again that healthcare is ungodly expensive in the United States.
So it is, I think, the right answer, to the extent that I could be so bold as to offer my own views. I agree. I see nothing but trade-offs in the real world, and I see nothing but wishful thinking in the political world, and arguably the journalistic world as well. And we'll get into why these trade-offs seem like universal laws as opposed to a matter of opinion. But certainly you see in every country, and I know your group has really researched countrywide comparisons, almost a perfect corollary relationship between supply lines, or length of wait times that are a function of supply, how much medical supply really is there, and levels of investment. And you see a misunderstanding of what it means to be covered. The UK is a great example because it's one of the best examples of a universal coverage model and single supplier model, but you see actually an inverse relationship between amount of coverage and number of suppliers and amount of actual medical supply measured in wait times. And so that is a perfect trade-off. You want everyone to be covered. You want everyone to say that they have free healthcare. Be willing to wait years to see your physicians and get the necessary treatments, certainly when it comes to high acuity surgeries. So these trade-offs, I mean, they're everywhere. You want a lot of investment in healthcare, people have to make money, right? There needs
Absolutely.
to be an incentive for that investment. Very well said. So if we're looking at those trade-offs as they exist today, what can we explain is happening in the industry right now? We're seeing less government funding in the form of those subsidies. And as a result, we're going to see less coverage. As a result, we're actually going to see higher premiums. So while we're taking supply out, the remaining supply is becoming more expensive, which is interesting. In basic economics, you would actually expect the opposite to happen, right? But in healthcare, as we're reducing this subsidy, what we're left with is the cost of the remaining patients that are covered is going to be a fairer reflection of the actual costs incurred. And I think one of the realities of our industry is that someone's always looking for someone else to blame. And so it must be the payers that are exploiting us if premiums are going up by double-digit percentage points. Never mind what those payer profit margins are. We won't do that research. It turns out payer profit margins are historically quite low. And so the counter argument to that is, well, the CEOs are getting paid a lot of money. And so therefore the fix must be in. They're not prioritizing profit margins. They might not even be prioritizing stock valuation levels, equity valuation levels. They're prioritizing their salary packages, and they're paid in the measure of tens of millions of dollars. So therefore, there must be exploitation in the system. What are your thoughts when you look at the different culprits that are often promoted as fait accompli evidence of abuse, whether it's overpaid payers, monopolistic payers, overpaid health system CEOs, monopolistic health systems, overpaid intermediaries, pharma benefit managers, and their very well paid CEOs, overpaid physicians running around driving very fast cars and living in very fancy houses. When you look at these pockets of real wealth across healthcare, how do you process those data points within the context of this question of trade-offs? Is the system broken as a result of that? that evidence.
So I want to take this sort of in two parts. The first is that you are correct. Everybody wants to find the one blame for all of this, the silver bullet of how I fix it, when the truth of the matter is that everything is to blame. I could, every single group that you mentioned and more is responsible for overspending in the United States. I wrote a blog post series, I think in like 2010, which was largely based on a McKinsey report, but bringing in other data that looked at, really why does American healthcare cost so much? And the answer is it's everything. Everything costs more in the United States. Physicians get paid more compared to the average citizen. Nurses get paid more compared to the average citizen. Pharmaceutical companies make a lot of money. Hospital systems make a lot of money. Insurance companies make a lot of money. Everything. And the number one overspending area is outpatient care. It's not, we could eliminate all the insurance overhead, period. And we would still be by far the most expensive healthcare system in the world. We could make all pharmaceutical spending zero. We'd be the most expensive healthcare system in the world. We could refuse to pay any physicians at all. We'd be the most expensive healthcare system in the world. It's everything. And again, it gets back to, I think, price is just how much we charge. The problem with that is that everyone is to blame, and fixing that requires some kind of external pressure, which will hurt. What is it? 18, 19% of American GDP is spent on healthcare.
Usually,
If we
historically, 17.6.
Okay,
Yes.
it changes every year. It's an enormous amount of money.
And
Reducing that,
the largest employer in the country.
absolutely, and so
And worth
reducing that,
noting that U.S. labor is the most expensive labor in the world in many respects, especially when you scale it.
yeah. And
So
so,
it's one thing to hire one or two engineers out of Liechtenstein. I'm sure that's very expensive. But in the US, if you're trying to employ 17 million people, which is last I checked, I think the number that we employ in US healthcare, they're going to be awfully expensive.
yeah, everything
And
is.
we have a lot of regulations in the US that actually obligate US labor, right? Especially when it comes to clinical care. It must be US labor. Well, US nurses making $150,000 to $250,000 a year in health systems, in hospital settings, that's not cheap, right? Compare that to nurse wages in other countries. See
And
what you
look at,
find.
physicians too. We don't produce enough physicians in the United States, and we also, keep needing to therefore import or have a fair number of our physicians who actually come from outside the United States. And but at the same time, we're limiting immigration, and we're making it even harder for people to come into the United States.
And banning overseas virtual care, which would
Absolutely,
be
and
such a
well,
deflationary input.
even trying to reduce levels of state to state, telehealth when it's possible even. So there's all of these reasons in place, but of course, all of these are designed in some way to bring someone more revenue. And when everyone is trying as hard as possible and in all different directions to do that, you wind up with a system where everything just keeps getting more and more expensive. At some point, if we said, okay, it's a real problem that we have an access and we need therefore to increase access, well, that will hurt somebody. Someone's going to have a trade-off. And so it gets fought. And if we say, okay, well, let's not do that. Instead, let's find a way to bring down costs. Well, that will hurt someone. And when it's 17.6 or whatever percent of the economy, everyone is going to feel that. It's not like we can only make changes and a small group does. Huge numbers of people make their money in healthcare. Changing
But
that.
I don't want to create the wrong impression. My view of our industry is that it goes through massive change all the time.
Okay.
Stochastically, every day there's change. Different operators are finding new solutions. Different innovators are introducing new products. Tech innovators are providing new software. And regulators, occasionally, every couple of years, are introducing a Medicare drug negotiation policy, a change in subsidies, a change in reimbursement rates, a change in reimbursement programs. We're now introducing mandatory facility value-based care models. Right? We're moving into specialty care, value-based care, according to the latest coming out of the Medicare Innovation Lab. Right? So there's constant change in US healthcare. I don't want to create the impression that it's stuck. What's
Now,
interesting is that when you add it all up together, we've remained somewhat stuck at 17.6% since 2008.
and that's
Ignoring COVID. And yet on a relative basis, that's success because you got to study history, right? For 50 years, we grew from 0% to well, maybe not zero, but 1% to 0% was 250 years ago. From 1%, we grow to 17.6%. That that growth was somewhat painful, but we've remained stuck. Other countries, not all of them, but many of these OECD countries and G7 countries have seen their spend on healthcare increase during this same period of time. What was 10% in France and Germany is now 11, 12, 13%. So on a relative basis, actually that gap has been shrinking. And then, how complicated is the topic? We can go layers and layers deep, right? 17.6% adjusted for US unique obesity levels, which at our scale is there's no other country with 350 million people that has 45% obesity,
No, that is
right?
true. But I'd also argue that and this is where it's like there are other interesting studies. I think blaming this on obesity, is I think even if we reduced our obesity, we would still be
I
by
think that
far
you're right because
the
we've
most.
done that maths. We have actually adjusted on our end here
Right.
at scale for normalized obesity, and you still end up at 15, 16%, which is higher than everyone else. Adjust for normalized diabetes rates and so forth, and the spend in these areas, in these chronic obesity medical areas. But then you still can adjust for percentage of GDP income that actually is a net positive and not waste, right? Not the stuff that you're overspending on, but the stuff that is actually good investment.
Yeah.
So our investment in data, our investment in software, our investment in drugs, what we export, right? That's also bundled into the 17.6%. Interestingly enough, across the board, and tell me if you disagree, globally, no one's including senior care in their healthcare spend, which is a whole other piece of this puzzle, which is very
The
interesting.
long-term care is not in there at all. I'm like,
Right. I would argue that actually the US grossly underspends on
yep.
long-term care.
I would also argue we underspend in public health and we underspend in a variety of other areas, which are, it's just not considered what we would say health
I
care.
think we underspend on preventative care. I think we underspend on food safety and national exercise programs. We underspend
That's,
on.
yeah.
So it is interesting when you really start to piece it apart how all these things manifest. When you look at foreign countries and you've done the research,
Uh-huh.
what trade-offs do you see in these other countries that you find noteworthy? And I know I've read some of your work. The fact that you highlight that you really have to look at these countries very carefully and not be lazy when it
Yeah.
comes to the
Yes.
label, right? These countries are partially publicly funded,
Yep.
partially private funded, right? You'll
Correct.
find private insurance in 10, 20, 30% of patient care in many of these countries. They are partially publicly employed, like the VA over here. In many cases, they're publicly funded and privately employed,
Yep.
right? Money
Yep.
might be coming from the German government, and yet still it's private practices that are receiving that money, and they're not employed by the actual government. So you have the free market system competing for those funds as opposed to a single supplier, right? Anytime you have a single supplier, it's a monopoly.
Yeah.
Whether it's a private monopoly or a public monopoly, it's a monopoly.
Yep.
And everyone should be aware of the risks of relying on monopolies.
Yeah.
So, as you look at these different countries, where do you see interesting trade offs? What are some of the countries that you think we can learn from with a big caveat? They're probably not taking care of 350 million people.
So it's interesting because there's sort of what I would ideally do and what do I think like we could really head towards are different. I think that the biggest differences between us and others are not as much an insurance design, which is all we ever seem to focus on, but are on the delivery of care. Because most countries, most sort of well-resourced countries, tend to provide most of their tertiary care in public systems, systems which are owned or at least run by the government, because that's where most of the expense is, and therefore there's an incredible pressure to keep it down. Even systems, though, with vastly public systems where they're allowed more private, are mostly in the primary care side, where the expenses aren't as great and there's much more room for, say, competition or for shopping around. But in the United States, like
So, when
we
you
are
say tertiary care is mostly provided, you're talking about acute, specialized, downstream care,
hospital care,
the heavy duty stuff.
inpatient care, or real specialty care. Most of
So
that
you're
is
saying
provided,
when it comes to real healthcare,
yeah,
governments do a
publicly
great job.
provided.
Yeah,
In the United States, we have very few,
right.
very few Americans
Very
get their
few.
care in public hospitals. I think that's the single biggest difference in what differentiates us from the rest of the world. And the second is if you talk to, some countries, I would also say sometimes the investment in prevention and in public health. Now that is often touted in America as the reason why we are so expensive. I disagree. I mean, I actually think prevention doesn't save a ton of money, but it does improve outcomes. It does make people healthier, and it's incredibly cost effective. And therefore, it's a good investment that we don't make to result in outcomes. So, what countries do I think we could learn a lot from? I mean, I love Switzerland's healthcare system. I think that Americans could get a lot out of that because, again, in a way, I feel like in a normal time, I could pitch Switzerland as a very conservative with a lowercase c healthcare system. Everyone gets private insurance, birth to death. There is no Medicaid, there is no Medicare, there's no VA. Everyone is buying private insurance uncoupled from employment. You could have the same insurer from the day you're born to the day you die. Everyone has the option of a tightly regulated nonprofit insurance, or they could buy private insurance if they like, sold by the same insurance companies, to access the more private system. Vast majority of people choose the public option. They choose the low cost, tightly regulated nonprofit insurance. But there is an option for those that want to have private insurance, which might have more bells and whistles, to go to the private system, which is much more expensive. But the care that anyone can get in a public hospital is pretty darn good, and their outcomes are spectacular. They have out-of-pocket minimums, not maximums, because they also believe that, they want to sort of drive healthcare spending down in that way. It would seem like something that, conservatives in the United States could get their head around, but you can't just take it one bit at a time. You also have to take that delivery system, which is something the United States has never really discussed, and certainly, there's no discussion of it at all in changing our delivery system. That's why spending keeps going up so much and why it's so high, because that's sort of the way that other countries do a little bit better job of reining in healthcare spending. Now, there are trade-offs. We in America don't love publicly run things in general. We also like our bells and whistles. We also, for all our talk of free market, we have less tiering than other countries do explicitly. You go to Singapore, which again, very, very private system, except for when you get in the hospital. But they explicitly have levels of A, B plus, B1, B2, where you choose your own path. And if you want your own doctor and you want to be in a single
VIP treatment,
in a
VIP
single room,
programs.
you're going to have to pay. But if you're willing to take a 10-bed ward, open room, get any doctor you want, no air conditioning, you can get it for free. And they explicitly allow those choices. And all these other countries, even England, you can choose NHS or private. And they're very different in their wait times. They're very different in sort of the
Yeah,
options
just to make it
available.
clear, a private hospital
Yeah.
only for private insured patients.
Yeah.
Very common in the
Yeah.
UK.
But in the United States, we think that
Find me one in the US.
even people on Medicaid should go to the same hospital and get the same care as people who are willing to pay a gazillion dollars out of pocket.
Yes.
Like, we do not allow for tiering. We do not offer a low cost, no bells and whistles, more wait time, whatever option to people that they could choose. And that, I believe, is the single biggest difference.
They'll offer you a VIP room, but very quietly.
Yeah. Yeah. And to be honest with you, it's not really based on how much you're going to pay.
Right.
It's, we even, like, these days when we have concierge care, you don't actually get better care. They just answer the phone better. They just, it's like, again, bells and whistles, like you're just more likely to get an appointment with the same doc you want on the day you
It's
want.
so interesting. It's such a salad bowl. And it's so interesting to see you say it, because as an outsider living in the US for the last 30 years, it is amazing how socialist a lot of the
Yes.
US fabric is across many industries. The
Without
fact that
any recognition of that at
our
all.
sports teams, NBA, NFL, are all monopolies. There's no such
Yeah.
thing as relegation. There's no such
Yeah.
thing as promotion.
Yeah.
They're just there. That is not competition. That's a
No, and it's a
fix.
cabal. No one can get in. No one can get out. I mean, it's funny you bring it up. I'm a huge, I follow a lot of football in England, and it's like, my favorite team is like just got promoted to League One. It's the greatest thing in the world. This idea that, you can get in and out, but the NBA is a cabal. Like, you can only,
I think they
by
call that
them voting, allow
meritocracy.
another team in. Yeah.
That's called meritocracy. We don't have
Yeah.
it.
No.
Yeah, no, we have. It's interesting. We have 7,000 hospitals still here in the US, a much smaller number than we used to have for twice the population size, right? We used to have 10,000 hospitals taking care of 150 million people. We now have 7,000 hospitals taking care of 350 million people. So somehow that's supposed to be deflationary. Good luck.
No, and it's like, and even when we did when the Affordable Care Act came in, and they said that we're gonna really start trying to push people to have more consolidation, and we're gonna have, what I can't even remember what they called it at the time. But I kept saying, like, if you force all of the doctors to leave their single practices and get together, then they have higher negotiating power. That will drive healthcare spending up. That is not going to reduce healthcare spending. And you can
At a
try to
certain
make it
point, that's
efficient.
true. That's one of the paradoxes of economics, is that
Yeah,
at a certain point, if you follow the line of success to its end, you get to monopoly pricing. What's interesting is that you actually do want that line to be followed just before that end. Because up until that point, you get economies of scale, you get
right.
competition, and you get the benefits as a
Yep.
society of good companies competing at their best. Once you go to that last stage and you're down to the one remaining survivor, all hell breaks loose when it comes to pricing. So it is a bit of a rub. You want it, but not too much, like
No,
chocolate.
and then you get sort of Medicare, which is a sort of a monopoly for those over the age of 65, but you remove any of its negotiating power or power of being a consolidated they don't negotiate. So it's like they're the one monopoly that really doesn't. And therefore it might, consolidation of insurance companies could theoretically drive healthcare spending down, because if it's the only game in town, hospitals have to take whatever it is. But we encourage, sort of competition in that area, which doesn't give us the negotiating power to drive healthcare spending down. A
It is
lot of
a
the
it is a
regulations we put in place are not, yeah, get us results.
very difficult industry to get your head around, right?
Yeah.
You're an average citizen, myself included. You wake up every day and Blue Cross Blue Shield, United, Cigna, Aetna, these are huge companies. These are plus $100 billion businesses. Why can't they do their job? I mean, I turn to you, Aaron, and I agree with you. There is nothing fundamentally broken with insurance. Fundamentally, insurance is the best thing we have got going for us in healthcare.
And it's the only thing we
It
argue
is the
about
right
changing.
model. And I would attach second to that government funding. That's the second best thing we have going for us in healthcare. Why? Because third on the list is me. And I really don't want to negotiate pricing for my next shoulder
No,
replacement. I
no,
don't
and,
want
and
to.
we can't.
I mean, notwithstanding, and with all due respect to ChatGPT, I love it. It's awesome. I still don't trust myself to negotiate the price of my next shoulder replacement surgery. I just
No, and
don't.
shoulder
You know
replacement.
who I do? I trust an entity that's processing millions of claims per year and has spent the last 100 years evaluating that question. I would like, but yet, we get into all these pockets of dysfunctionality, and we struggle to process that. How could United, with all its vertical integration, it now employs 50,000 doctors through Optum. It is purely vertically integrated. It's high tech. We're going to interview the head of data analytics at United in the next few weeks. How could that company still struggle with hospital monopolistic power? Surely the fix is in. And yet it only takes a couple of zip codes for a hospital to say, you've got no other game in town. No one else is doing high acuity procedures around here. If you want my operating rooms, you're going to have to pay me a 10% premium this year. That's all it takes. And
Absolutely.
that conversation is happening 1,000 times per year in this country.
And I mean, the optics are always so bad, because at the end of the day, someone's gonna get denied something, because really, at the end of the day, insurance only has a few means by which they can reduce their spending. And one of them is saying no to care that they feel is unnecessary. But that line can be so easily skewed in the press and the media of what is there. And so no one wants to take the hit and the bad optics of saying no to something that's ridiculously expensive and not worth the money. But we have come in America to believe that that is wrong, and that everything should be paid for, and that there should be no discussion. And it's like that the math doesn't work.
I
And
love hearing you. I can't tell you how many podcasts I've had, and these are the industry leaders, where in the same podcast, I'm hearing we overspend on healthcare and I'm furious about it. The bills are excessive. And then in the same podcast, we underspend on healthcare. My constituents, my patients, my neighborhood needs more, and they don't know how to get it.
yeah,
And it's the same conversation.
yeah,
And we're stuck with this riddle of 5 trillion plus
yep.
spent annually on healthcare. And yet all we can do is point at areas of, insufficient supply.
And that's because that's how we fight the battle. That's how we
Yeah.
prevent, in
And then we
rhetoric,
throw in the
our piece of the
towel and
pie from being cut.
we say we've had enough of all of this. Let's just give it to the government. It's too difficult. It's too difficult to run. We'll have one supplier and we'll just all agree that they're dreadful and we'll all be right and we'll criticize the government, but we'll be stuck with whatever the consequences
But
are.
see, I think that, so that is where I get a little bit frustrated of another.
Universal care.
Yeah, because we could go look, you could go to a single, but we have a single payer system or some a quasi one in the United States already. It's Medicare. No one thinks Medicare is cheap. No one thinks Medicare could that we should just increase it or that it's not paying enough. We all know
Isn't
Medicare
Medicare broke?
incredibly expensive. And so the idea somehow that we would just transition to Medicare for all and then everything will be fixed, we will still have by far the most expensive healthcare system in the world.
Because they'll
And on
still be
top of that,
employing US nurses.
now we will just have one group to blame every time something goes wrong. We've
That's
never
right.
seen the government has the will necessary to say no in these areas to the parts that cost the most. All they can do that we've seen in the past is just keep cutting overall spending and then hoping someone else will take the blame. States, hospitals, someone else. So you can just cut Medicaid by hundreds of billions of dollars and say, oh, this isn't going to affect anyone. Of course it's going to affect someone. Otherwise, where's the savings? It's Medicare doesn't provide cash or cake to people. It reimburses for care. So if you stop paying it, someone's not getting reimbursed for care or care's not being received. Now you could try to fix that down in the weeds and say, let's stop paying for inefficient care. But they don't do that. They just make the cut up here and pray to God that something's going to get fixed below. It's not.
There's
And
gonna be
until
a lot of
willing to
bone
grapple
dropping,
with the
for sure.
reality,
This is not just fat, for
it's
sure.
not going to fix. It's never going to fix.
So given all of that, and given the Swiss model, given all your research, given all the initiatives underway in US healthcare every day, many of which do make the system better, not all, but many of which are net positives, given the ever growing role of technology in US healthcare and global healthcare, what are you most excited about, optimistic about, impressed with when it comes to our system today? What's the rosy scenario?
Well, I think where our system arguably shines for whatever else it does. I mean, we are pretty good at innovation. We are pretty good
You can
at
say best in the world.
okay, we are like we drive innovation. And I mean, let's be honest, we drive innovation because there's a lot of money to be made there. So it's like I
That's
get it.
another one of those funny trade-offs.
And which is
Most
exactly right.
favored nation pricing for
Yeah.
drugs,
It,
and you might not get that many drugs.
it's just that for $5 trillion or so, we should be able to spend that money a bit more efficiently. We should be able to, make sure that, but it would take some, we talk all the time about how, oh, we don't have enough primary care providers, we don't do enough. Well, it's like, that's because we don't pay them. Like, these are simple things sometimes. It's like, we don't pay them enough.
Have you taken a close look at our residency program
Yeah,
and the
absolutely.
strange reliance that we have on Medicare funding
Yeah.
to determine the number of residencies made available
Yeah.
on an annual basis?
Yep. And
Isn't
then
that a
and
bit
when they
isn't
tried
that a
to
bit
increase that, to increase primary care, that's where we'll say like, no, 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 let's not spend the
isn't
money
that
or
a
let's
bit
not.
odd? So
Yeah, it's
you
hugely
have
odd. It makes
100
no
of the
sense at all.
largest health systems in the country, the
Yeah.
Sinai's and the Cleveland Clinics and the HHS's and all these massive systems, right? And the Northwells of this world, and they sit on $5 to $20 billion portfolios, balance sheets, and they employ tens of thousands of people, and they are academic institutions,
Yep.
and they teach for a living.
Yep.
And Medicare is telling them that they can only provide 2,000 residency programs this year. And Medicare is referring to the latest policy that defined number of residencies, which was determined, I think, in 1985.
Yep.
I'm not that far off in terms of
Right.
the date. It's
Yeah.
about 1985.
Yep.
That's what we got. And that funnel, the 50 to 100,000 residencies, I get two different sources on what the actual number is, but 50 to 100,000 per year. That results in everything else. Everything follows from the number of physicians graduating residency programs every year in this country.
That
Everything.
benefits physicians. And I'm one, so I'll take the blame on that too. That benefits physicians. I mean, fewer physicians getting trained means that my salaries are safe and my employment is safe. Because again, it's it's somewhat of a monopoly. And
I
it's like,
don't think we're spending enough time on this topic as a populace.
we don't spend a lot of time on all of this again is where they somehow the wool's been pulled over. We spend almost, it feels like, all of our national time arguing about whether we should have
Insurance.
status quo or single payer.
On creative alternative insurance and reimbursement models. But meanwhile, it's the same 50,000 doctors that are graduating every year. And our population, up until this year, our population has grown every year. This year, I don't think it will due to net migration. But you can't have less and less hospitals, the same number of doctors, and double your population and not expect inflation,
No,
meaningful
but again,
inflation.
we're still spending all of our oxygen arguing about the Affordable Care. I mean, literally today, they're still arguing about the Affordable Care Act, which was like 15 years ago, and truly was just talking about increasing Medicaid so that 16%
Well,
of the
this is when, so again, we were talking about lines and following these lines. So some Keynesian policy is great, right? Government's getting involved with high acuity cases, negotiating as one. We've got this. We'll take care of most of the hospitals. Avoiding 10% annual inflation rates in hospital care sounds good to me. Too much Keynesian policy, the world falls apart. Hey, we're going to fix healthcare with ACA. We got it. It's all fixed. Nothing to see here.
Which is funny because the United States thinks the rest of the world is socialism. I mean, that's just what we think. And the truth of the matter is that what you described with that combination of a public and a private delivery system is what almost every other country does. We don't. And I think that, again, is the biggest flaw or the biggest problem. Like,
With
and we keep trying to
with
fix it with
hospitals.
Band-Aids everywhere else. It can't be fixed that way.
You're talking about hospitals. We
Yeah,
have,
what
out
providing
of
care.
7,000 hospitals, only 1,000 are government run, really.
Yeah.
And I would
And
say
even then,
of those, I think several hundred are VA. So you're
and I
left
would
with
also say like
yeah.
outpatient, outpatient even, but very expensive, chronic care or specialty care. That too, because we've shifted a lot of our hospital care out into what we consider ambulatory, but
Yeah.
it's still expensive, and that is a major driver of expense as well. But the most expensive stuff probably needs more public involvement in public delivery system to drive down the cost of that, while allowing for a market and a private, outlet for those who perhaps want to spend more, which is fine, which is what most every other country does. But we don't do that. We are the opposite. We're like the vast majority of people, even those who are on public insurance, get their care in very expensive private systems.
It is interesting that Medicare and Medicaid, I don't think they run any hospitals.
No.
And the only government hospitals are really state-run hospitals.
No.
across this country.
And federally qualified health centers, the only thing we really allow are delivering primary care, which is very cheap. So the idea that we're going to squeeze on that is silly. Like, there's not much squeeze left in primary care. Even private practice primary care is not a moneymaker.
So going back overseas, what are some of the developing countries' health systems that you look at and think, that's very impressive what they have going on?
Well, I mean, I find
I got a glowing report from a Nigerian.
yeah.
They loved their model. They'd since moved to Denmark. They said, hey, Nigerian healthcare is much better than Danish healthcare. That's very anecdotal, but it does raise the question, where are you seeing excellent care in places that you wouldn't expect?
Well, I mean, years ago, I got to go to visit Malaysia's healthcare system, and I was actually rather impressed. And they were focusing very much so on, tourist care, people actually coming in for specific care because they could get people to come in from neighboring Asian countries, even higher resourced Asian countries who were experiencing delays.
That's always a clue.
Yeah.
Where are the tourists going? That
Yeah.
tells you a lot.
Yeah. And so
And where are they fleeing from?
Yeah, that was really interesting. And I also find, I mean, I know it's not developing, but Singapore's healthcare system is really interesting to me, especially in their sort of ability to balance, I think, what you sort of were describing, like the balance of what government should do versus not making government do too much.
And that's really the rub, isn't it? That's
And a
the rub.
willingness to change their mind pretty rapidly, and actually using various policy levers in other sort of interesting ways to drive healthcare and healthcare spending. Like, every time I go to Singapore, and I've been there, I think, twice to look at their healthcare system, and when I've been lectured elsewhere, they spend an enormous amount of time talking about their housing policy because they recognize it's an incredibly important driver of overall health and healthcare spending. And they also are very cognizant about, like, where are we putting the hospitals? Where are we deploying this stuff? How are we making sure these areas are covered? In ways we don't. Like, we're squeezing our rural hospitals to death here in the United States, when we recognize that, like, that's probably where we need some investment, because there's going to be major consequences to that. But we are unwilling again to get in the weeds
No.
in areas, and it probably needs to be public, because again, you're not going to make a ton of money in a rural healthcare setting. So yeah, where the private market's not going to work is where the public needs to step in.
We have a $6 trillion federal government, and they seem like they're out on vacation.
Yeah. Well, no one wants, again, it's the trade-offs. Everyone, all they ever want to do is point out problems with someone else's policy prescription without ever
So true.
acknowledging there is no policy prescription without negatives. It's all trade-offs. But they pretend like their ideas have no trade-offs and someone else's does. Or by never providing any ideas, you just don't ever get attacked. But there is no way to fix this without someone getting hurt in some way. And so it's just reality.
So we have many issues, but I don't think our system is falling apart. Um, it's just a perfect punching bag for critique, for criticism, because it deserves it, right? There's so many things that we can improve in our system, but I would call it in aggregate relatively stable. I don't buy into the concept that, the government is Medicare program is going bankrupt, that social welfare is going I don't buy any of that. And maybe I'm wrong, but I just call it I'm honest in what I see. So I think our system is dysfunctional, stable is the way I would rate it if I was a healthcare rating agency. I do think the UK system is highly unstable and unsustainable in its current model. I think they've gone way too far in single care, and I think they've run out of supply. I think there's a strike right now today in the UK, and I don't think it's uncommon. Doctors and nurses striking in the UK is very common.
No, but we could
What
fix
they
that.
pretended was the envy of the world, it turns
Right.
out was a pretense. Because when you rely on one source of funding, what you find is that any source of funding is not that reliable anywhere in the world,
Right.
right?
No,
And
but
so
I'd argue
are there
they're
other
under.
UK
Yeah.
examples that you look at and you think, is it Canada? Is it France? Are there other examples that you look at and go, wow, that is very, very volatile and it's all falling apart over there?
So, well, I think, actually Korea's got a real crisis that they just fixed of striking junior doctors, but that was actually because they were trying to increase their supply of physicians, and the physicians basically went on strike to
To
say,
your
don't
point
do that.
about the
Yeah.
US,
Yeah. So it's like,
the
so I mean,
US,
that was a
the
real
US
problem.
physician supply constraint is perfect. They buried it in a
Yeah.
residency program that no
Right.
one thinks about.
Right. So,
Perfect.
but it's I see it less in crisis than what healthcare system do I think is not great? Ironically enough, I don't think Canada's is that great. And they don't have as much of a private outlet. They really force people to stay in the public system. Therefore, they have significant wait times that people complain about with no way of getting out of it. It's ironic to me that that's the system that we always point to in America is like, that's a great option. It's like, that's the one I wouldn't pick. Like, there's so many good options in Europe or even in Asia of like, okay, those are interesting models I might actually consider. I don't think that Canada's healthcare system is that great. I actually think that they need probably to increase their ability for people to have other options.
Private capital partnership.
Yeah, like again, it's what you said before about having the balance. The balance is necessary. The United States is too often one direction. I think Canada is too often the other direction. I'd argue it, and when you're talking about things like Britain, it's like, yeah, that needs more investment into supply. That would cost money. What kills me about America is we're already spending way more. Like, we should have it. Like, we could spend this money better.
We could have the same conversation about education, which is another one of those industries that is perfectly structured for public private partnership done right. We couldn't have this conversation about banking. Banking skews all the way to private. There's no reason for a public government funded bank. The underwriters underpinning all of that are public, but that's very different than outward facing. There are countries that are still publicly run banks. They don't tend to be very competitive.
No, and it's like, I would never want a publicly funded pharmaceutical industry. I would never
Yeah.
want it. I mean, a publicly run
It is actually interesting. Our defense industry, or now we call it our war industry, is skewing more towards private now.
Yeah.
But not private oligopolistic, private new entrant with the emergence of low cost military tech and military hardware. So that's a very interesting time to be in defense, what was historically very public plus oligopoly. That's it. That was the entire industry. So you find these different industries where really the big question is, where are you on the continuum of public-private relationship? Is it 50-50? Is it 80-20? Is it 100-0? And a lot stems from that. And then once you've gotten that ratio right, where are you in terms of honest discourse,
Yeah.
right? Honest dialogue. Because if you can't have honest analysis of your own industry, you're not going to fix anything.
Well, we are nowhere. Yeah. I think in the United States, when it comes to healthcare delivery, we are nowhere near sort of what the
There's a lot
optimal
of
number
bias
is.
in the US, a lot of bias.
And I think we have very little honest discourse.
Cognitive
I mean,
dissonance. Yeah.
I think it's both of those things are way off in the United States. I mean, everyone thinks our problems are just insurance. Truly, like it's so much. If we could just have single payer, it'd be wonderful. Or if we could just have free market, it would be wonderful. And
Stop
it's like,
those
that's not our
overpaid
problem.
CEOs. That
It's not our problem.
it's not going to solve for a lack of residencies.
No.
Aaron, I really appreciate your time today. I really appreciate all the work that you've put into getting to this point where you have such a deep, rich understanding. I hope that you have many more microphones and that you can spread the gospel on how we build a better industry, not just here in the US, but overseas as well. And I really look forward to staying very close to you over the months and years to come.
Please,
Thank
that'd
you.
be great.
Thank you for
so
all
much.
of it.
Thank
you,
you.
my friend.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.